For years, clinics were forced to do more with less. Then something changed.
CCBHCs.
CCBHC.
Central feature of the CCBHC model
Or CCBHC.
What are CCBHCs, and how are they helping clinics in cities and small towns go from
If I address the crisis here at 12:45 over my lunch break, and I know I've got a 1 o'clock client scheduled, somebody somewhere is going to probably not get seen.
to expanding care, building teams, and collect winning stories like
Just found out yesterday, one of our peers who she and her entire family had been through our services. She lost her law degree and her kids. She became an LPC, but she just found out yesterday that she also passed the bar. It's amazing what we've been able to do.
Learn about the impact of CCBHCs and more on this episode of Wellbeing Wednesday.
Hello, and welcome to Wellbeing Wednesday. We're here today to talk about CCBHCs, or the Certified Community Behavioral Health Clinic model. I'm Rebecca Farley-David. I'm a senior advisor at the National Council, working on all of our CCBHC efforts across the organization. CCBHC, for those who might not be familiar, is a model of delivering and paying for integrated, whole-person healthcare that supports clinics with the cost of expanding access to care, launching new services and activities, and meeting the whole needs of their populations. I'm joined today by Shauna Reitmeyer and Vera Sansone, who I have known and admired for more than a decade now. Shauna and Vera, could you please start by introducing yourselves?
Well, hi, Becca. Really good to see you, and it's an honor to be here. I am Shauna Reitmeyer, and I have the honor to serve as the executive officer for Aluma, a CCBHC in Northwest Minnesota.
I'm Vera Sansone. I'm the CEO at CPC Integrated Health, which is in New Jersey. I have been so involved with CCBHC from the very beginning and with Rebecca. So it's really a pleasure to be here.
Well, thank you both. We were talking earlier about how it feels like we're just chatting about CCBHCs the way we have so many times. And I was wondering if we could start, you both have been CCBHCs since the beginning, so since 2017. And I'd like to start with having you both tell us a little bit about the communities where you're located, and then take a trip back in time to the 2010s when you were first thinking about this new thing that we were all learning about called CCBHC. What made you want to become a CCBHC, and how did you see it addressing some of the challenges that you were facing at that time in your communities? Maybe we'll start with Shauna.
That is a really good question. I think when CCBHCs came about and we heard about this planning grant, right, that was being issued, and we really strongly, through our state association, partnered with them to work with our state. And we really advocated with our state department to say, let's jump on this. And the reason for that was, I think it finally brought together all of the pieces of a service delivery model in an integrated way, with a payment model that I think allowed us to really bring all of these comprehensive services together in a way that we hadn't before, and we're in a very rural and remote part of Northwest Minnesota. We're a very agriculture focused community. I always like to say that we are about the geographic size of the state of Vermont, but the difference is Vermont has about 70 people per square mile and we've got 4. And so our total population is about now, it's grown a bit, surprisingly, since when we first started, but we have about 80,000 people in the 8 counties that we serve. And so it really allowed us to, grow the services. And, as we get into this, I can talk a little bit more about that. But I think for our rural community, it allowed us to fully operate, bring all of those core services into play in a way that we hadn't before, that were very siloed, very, segmented, and we were able to integrate our services.
Vera, you're in a very different part of the country.
So in terms of the whole health kind of thing, we very much that the pieces that were missing and the ability to bring it all together was just so appealing. And I had been at National Council conferences for a couple of years before where we were just starting to talk about that, and it sounded so exciting. So so that piece definitely I resonate with. In terms of our community, so we're in Monmouth County, New Jersey, which is a very interesting county in that we have some of the most expensive areas as well as some of the most challenged areas. And everything is difficult, the transportation, housing, and we saw the CCBHC as ways that we would be able to provide case management and do things that we have not been able to do before. And we've always worked with the those folks with SMI or co-occurring disorders. This was another opportunity to really focus more on that population. So that's what we were attracted to. But in total honesty, New Jersey had decided to go to fee-for-service. And they were going to fee-for-service literally the same day that the planning grant was starting. And so we figured we're not sure what's going to happen with fee-for-service, but we're certainly not going to be able to add any services to what we do. So we went all in on CCBHC and wound up registering 3,800 people into, at the very beginning of it. So that's how we started out in CCBHC.
Yeah. So let's talk about that payment model because, when I hear from CCBHCs about some of the work they've been doing, it's not always that the innovations are new. It's often that the financing that supports those innovations is finally there in a way that allows them to expand and scale and take on new work they hadn't been able to do before. So maybe, Vera, let's start with you since you brought up fee for service. Can you talk to us a little bit about how the payment model supports what you've been able to do as a CCBHC?
It was hard to believe, actually. We'd sit down and talk about prospective payment, which is something we never, we were barely able to look at the budget each year and figure out how we're going to cover what we're currently doing. And this way, we're actually planning for what makes sense and building things in like training for the staff, more staff who come from different types of backgrounds. So adding APNs, adding occupational therapists, adding the pieces that, having been in the field as long as I have, these are the things that you always, wouldn't it be great if we had fill in the blank crisis services, all of these things. And which with the PPS rate, we were able to do. And I think there were only two of us that had the monthly rate. And I think it was us in Oklahoma. Everybody else had the daily rate. And at first we were like, oh, geez, this is not going to be great. But I have to tell you we've been able to have outlier kinds of stuff. I mean, it has turned out to be really an effective thing. So I was always jealous of the FQHCs when we'd go to meetings there and they talk about their, payments and be like, well, why don't we have that in mental health? So here was the opportunity.
Yeah.
Yeah. Wow. Was the payment model a shift, for us? Because being a very fee-for-service based model in Minnesota prior to becoming a CCBHC, and especially in that first year where you can have those anticipated costs, it really opened the door for us to strategize, plan to bring on different resources. So we always joke about the old salmon colored piece of paper that our, front desk staff, if they had somebody that called for crisis services in the middle of the day, we didn't have a dedicated team like we do now. It was whoever was readily available to take that call. And it wasn't that, clinicians didn't want to take that call. It was, if I take this salmon piece of paper and address the crisis here at 12:45 over my lunch break, and I know I've got a 1:00 client scheduled, somebody somewhere is going to probably not get seen, and so it was always this juggle, right, of who's going to do that. And so, as Vera said, right, getting to do crisis services, we always did them. But what we got to do was to create a dedicated team. right? We got to bring on more peers. We got to bring on more APRNs to provide services, expand our medication assisted treatment services, right? These things that were always, right at the bare minimum. And, at least we can say, okay, we have them. Now we've got dedicated teams. I think one of the other things that I think was really critical with this payment model as well is because it's based on your costs, and we know the majority of our costs are our people, right? And we were able to then really move from, not that we didn't want to compensate our staff, but it was a challenge of how do we keep up with the costs of staff. It used to kind of be, all right, we're going to get people at the, lowest rate possible because we can't possibly meet people at market. We're at market now. Where we weren't able to be before, which was huge, right? That's helped us with some sustainability of our staff. It's helped us with growing our staff, being more competitive in our communities where we were kind of the last ones. Now we're up there with our primary care providers and our county partners, where people can see career paths. They can see that they get to do their mission driven work that they want to do and get compensated for their care. Now, are we exactly where we want to be? No, right? Because we know inflation and all of those challenges. So I want to set the stage, right? There's still challenges in workforce, but we've been able to be much more competitive than we've ever been before.
And that echoes a theme I hear so often when I talk to CCBHCs is how this model has allowed us to invest in the workforce and not just invest in hiring new people, but also creating an environment where people want to stay. So I wonder if we can talk more about that because Shauna, coming from a very rural and frontier area of the country, I know that recruitment is a big challenge. Has being a CCBHC and making some of these changes allowed you to overcome that challenge?
I would say we're still chipping away at it. Okay. It's not completely overcome. I think just as a whole, we don't have enough people going into this industry, right? But what it has done is it has allowed us to invest our resources in different ways that we hadn't before. So we've been able to put money into our budgets around tuition reimbursement. So we're really trying to invest in how do we grow our own employees, right? This year, I think we've got 6 employees that are moving on to their master's program, and we've been able to help support that. We're maximizing, all of the funding that we can possibly do through, National Health Service Corps as a rural provider as well. But we have such an array of disciplines now that we've got people that have lived experience that through coming in and being a peer are going back to school, right, to get their bachelor's degree and becoming social workers or going on for their master's degree. So what that has done is it's the pathways that we're providing that we really didn't have the opportunity before. If that makes sense.
Absolutely. Yeah. And, Vera, I've heard a lot from you as well about your workforce investments over the year. And I'll never forget when I came to visit CPC and you showed me the new section of your building you had set up for ambulatory withdrawal management and talked to me about how this model helped you to hire nurses to staff that function.
Yes.
And so I'm wondering if you can tell me about the different kinds of roles that you've hired and how that has changed the team-based care available.
Yeah, that and that's a core change that has had such an incredible impact on our ability to really be an interdisciplinary. We always called ourselves interdisciplinary, but it was basically social workers, doctors, and case managers. Now it really we have expanded the scope of who we bring in. So APNs, this has made a huge difference. We have family practice nurses. And so the medical case management piece of it, they're overseeing, they get directly involved. We have occupational therapists who are an amazing group of people who kind of got left out of psychiatry when they changed the whole thing to having to be medical. So they couldn't bill for Medicaid, but with, coming into the fold under CCBHC, they can. And they provide such amazing services, helping people to go back to school, to, get jobs and, that kind of stuff. Peers, we have a similar sort of thing. I just found out yesterday, one of our peers who had been through she and her entire family had been through our services. She had been a lawyer. She lost her law degree and her kids. She became an LPC, but she just found out yesterday that she also passed the bar. So, yeah. So,
fantastic.
So it's amazing what we've been able to do. And we have a career ladder. It's like a cottage industry because we have the same problem. Not everyone wants to be social workers anymore. I think during COVID, when people saw that they could just have a private practice and do that kind of stuff, we did lose, some folks, but we're growing them ourselves. And so now we're able to help with tuition reimbursement. A number of our staff got their loans. And so that was amazing. And we're really trying to inspire even, folks that wouldn't usually go into the field, our support staff, who we've convinced, what the hell, give it a try, maybe a pharmacy assistant or, something else. So we've really broadened and we would never have been able, we had all the ideas, but in practice, we just couldn't do any of it without CCBHC. Mm-hmm.
I am thrilled for Nikki that she has her license back. That's just an incredible story. And every time I hear from CCBHCs about the work that you're doing, it brings tears to my eyes too, because of how life-changing these services and this kind of support is. Yeah. So let's talk about substance use care, because that's an area where we know there are still huge gaps in access. And even though recent data is showing a promising decline in the number of overdose deaths, there's still just way too many Americans who can't get access to the support they need for substance use conditions. So I'd love to hear from you about what you've both done to expand substance use care and what impact that has made on your communities.
I can go. I think one of the things that I pride ourselves on is how we really embraced addressing co-occurring disorders, from the inception, right, of the services that we provide. And we have been able to, again, over the years, bring in more and more of our providers that are duly licensed, so we have a true integrated approach to our care. And then by adding on additional substance use treatment, we now have our intensive outpatient program that we did not have before to really meet to have that continuum and that full array of services. And then just our providers, becoming trained, certified back in the day. Now, with the waiver changes and all of that. But we have most of all of our APRNs that are providing services, are providing, medication assisted treatment and addressing opioids, right? And not just opioids, because we still have alcohol is still our number one, right? That we're seeing. And so, we have, our jails that we're working with, the screening, our care coordinators, the screening that we're doing and bringing people in, I think are just critical from adolescents to adults, the partnering with our counties and our schools. We now have one of our LADCs that's in our largest school district, doing outreach and engagement with our kids and, trying to get them, how do we get in that prevention stage, into treatment of, can we break that cycle as much as we can? So, and without that and without CCBHC and the model that we have, it would make it really difficult for us to be able to do that. So we've really just expanded over the years for sure.
Yeah. And I know in rural communities in particular, many of those services are simply not available before.
No, they're not. Yeah.
I think another thing that we've done, again, that we couldn't, not that we didn't know it was important, but we just didn't have the time and nobody would, pay for the time, is the collaboration that we have with other providers and setting up networks. So for instance, we were involved in drug court, but that has now morphed into us actually going into courts and doing diversion. working with prisoner reentry and going into the jail and, working and all great ideas, all things that common sense, right? But we couldn't do that kind of thing. And we also started, we had actually gotten this idea from the Camden Coalition, who, I think people probably know, where they put together this breakfast that they would have once a month, and any provider, hospital, anybody in the community could come. They did best practices, CPT codes for billing, just to help people understand what was happening in the community. Because we had AWM, withdrawal management, we were able to hire both a family practice nurse who specialized in addictions, as well as a primary care doctor who she had decided that she'd rather be a substance use person. They also were able to offer help to primary care doctors, to pediatricians, to anyone who calls in to get advice about medication-assisted treatment. So we're also adding to the education of the community about substance use through those kinds of things. And those are things that I think really make a difference, but not the kind of thing that we would be able to do and that's in addition to expanding the services, hiring people who are comfortable, or even our child psychiatrists, while they don't want to be the primary person prescribing, if somebody's on vacation or, whatever, they back people up. So it really is a network, and working with the inpatient units and that kind of thing to either do training or to just make sure that barriers are reduced, and people can come in when they need the treatment. So it's been life-changing.
And so much of what you're both describing, I think, falls into that realm of non-billable work, things that we know are really important to helping people in need, and yet you can't bill a claim for them. So, that's another thing I love about this model is how it allows you to bundle all those activities and costs together and then get paid at a rate that supports the community education and the partnerships and all of those wonderful things.
So much.
And speaking of partnerships, one of the reasons I love working with both of you so much is that every time we talk, I think I hear about a new and innovative community partnership that you've put in place. And so, I think you both embody that central feature of the CCBHC model, which is that we can connect with more people by getting out into communities and reaching people where they are. And often that happens through our community partnerships. I know you have many, but if you could tell us about just one or two of the partnerships that you think have had the biggest impact on the people that you serve.
Boy, where to start on that, because I think that has been one of the core premises of being a community mental health center prior to becoming a CCBHC, and being in such a rural area. We really believe that we cannot do it alone because there are not resources, so Aluma in the 6 counties that we primarily serve as a CCBHC, we're the only organization that does what we do. And so we know that we have to partner with other organizations that are collaborating. And we're part of what's called the Northwest Council of Collaboratives as well, where it's bringing in all of the school districts in all of our counties. It's bringing in public health. It's bringing in human services, our law enforcement. And so we meet every month and we talk about ways in which we can collaborate. We've been able to bring in, hundreds of thousands of dollars through joint partnership grants, right? So we had this strong foundation to begin with, but what it did is when we became a CCBHC, it allowed our opportunity to say, hey, now we've got some funding also to support this. And so we've been able to expand and use the CCBHC model to be in our school districts, even broader than what we had been in the past. I think we've been able to be in 20 different districts throughout our region, whether we are co-locating and having our providers directly in those schools, or we provide supervision to the school social workers to do mental health work that they already have the ability to do where they didn't have that resource before, right? I think the other area as well is in our jail. So our largest jail is a 3-county jail. serves 3 of our 6 counties. And we've got 2 care coordinators that are co-located in that jail. And they work with screening, providing skill building and services to individuals in the jail. But then what they do is upon that release, they're doing that pre-planning. Right. They're working and identifying what are the services, where can they either come into a LUMA, or let's get them connected back into the community where they're going home to. We're helping connect to our housing support program as well that we have. So it's that true looking at those health related social needs that we know are so fundamental for people in order to be successful and actively engaged then in their mental health care. So without the partnership with the jail and being able to be there with the school districts, with our counties, with our crisis team is on speed dial with our local emergency rooms, right? When people are showing up there. So it is our CCBHC model is a full community kind of response model that we have. And I could keep going, so I'll stop now.
So talking about community partnerships, we've been involved with some of the local hospitals and the FQHCs. And what becomes clear is that at the community level, there's gaps with maternal health, actually with full spectrum of, women's services. So we decided that we would start reaching out to some of the practices in the area of midwives. We have APNs who have group practices and work a lot with Medicaid folks. And so we're going into those programs, teaching the APNs about how to handle mental health kinds of things, but also to establish a really seamless way for them to send people to us. We're doing a lot of work with postpartum. And then through that, kids, you're seeing the transition for the little ones, because while we see a lot of kids, the really young ones, we've had a little bit more difficulty figuring out how, where the best place to partner for that. So that's a growing thing, maternal health. And the other one is our legal partnership. We have the Law Project. It's a community program in the area that works with folks with disabilities. They actually come into our building, and anyone in our CCBHC who has any kind of legal situation. We have lots of things, everything from they don't have their birth certificate, they want to get something expunged, those kinds of things makes a huge difference in people's lives. And so that's available. And so I would say those 2 partnerships are some of the more unique things we're doing these days.
And I know when it comes to partnerships, we really could talk for hours about everything you're doing. The CCBHC model, it's 8 years in at this point. I do see a lot of momentum behind it, but it's not everywhere yet. And there are still a lot of people who don't know what a CCBHC is or how they can be of value to communities. So as we close our conversation, maybe leave our audience with your reflections on just one thing you would want the public to know about the value of this model.
Okay, I'll go. I think what I like to say about CCBHCs is it's this integrated model. It really has allowed our organization to look at delivering services in such a different way, and from a team-based approach to and when I say integrated, sometimes I think it's hard. Like, well, what do you mean by that? And sometimes it's hard to put that into words, because I think that, everybody looked at their service line that they were managing, from staff as it's, this static service. And, but I really like to look at it from, an individual's perspective. What is this a la carte, this menu of services that someone might need? But we come together with all of the providers that might be engaged and seeing this client, in a team-based way. We have this, what we call our care coordination zone, 1:00 every day. If someone is ending up in crisis, if someone is up for a treatment plan review, something is changing in someone's circumstance, we get to call the question and say, we need to meet as a team. That 1:00 zone, everybody gets scheduled. It was always like an act of Congress trying to get people scheduled. And we just said, you know what? Let's make time. Let's put time on our schedules. And so we now have an opportunity where all the players, all the providers that are seeing Shauna today get to come together along with Shauna, right, in that meeting to say, who's on first? Who's going to take priority, and what are we going to do in order to wrap around this person, to make sure that they're doing okay and they're getting what they need. We didn't get to do that before, and so it allows us to practice in a person-centered way to meet the needs of that individual in a way that we never used to do before.
Yeah, amazing.
I would say to kind of pivot a little bit, because we definitely the teamwork, definitely the care management and the integration. But I think for us, forward thinking, we really want to develop the workforce of the future and see what role we can play with the schools in our area, with developing CCBHC as a model that the schools get invested in. And so, we have a lot of interns and residents and all of that. And when they come to us, they're amazed by it, but they didn't know anything about it before they got there. And it'd be great if we could help the schools to, get a little bit more involved in the training for it. And then the other piece is the role of, I know some people don't, AI. We love the whole technology thing. And we think that there's so much that can be used, and we have the opportunity, to develop some of those kinds of things. So that's kind of like where we'd like to go next, figure out where technology can fit more into this and how we can help the workforce grow in this direction.
Mm-hmm. Well, thank you both so much for being here with us today. I really appreciate all of your comments, and I have to say I'm looking forward to what you're both going to do next.
Thank you.